You can see I'm just going to talk about the neurology or neuroscience of Parkinson's disease. We know that it is a neurodegeneration of the neurons, specifically in the basal ganglia. The basal ganglia is in the brain. It's a group of nuclei in the brain which help to regulate motor signaling. Motor, which means your gross type movement like flexing your arm or walking. So there are two main pathways that control or regulate this movement that we are talking about here, that is regulated by the basal ganglia. So in the basal ganglia, by the way, we do have the substantia nigra compacta. And we will talk about this because obviously you know that with Parkinson's disease, it is the substantia nigra that starts to lose its neurons, or it's the part that degenerates. These are the neurons that die off. So we need to talk about the two main pathways if we are going to talk about motor movement that happens appropriately. We have the direct excitatory pathway, which happens via glutamate, and the indirect pathway, we know this is due to GABA, which will be inhibitory. So let's start off with the direct pathway. The direct pathway, there is inhibition on the thalamus. Put that at the back of your head. Let's keep going. So this is what happens. So from your motor cortex, because for you to actually initiate movement at your extremities or your distal extremities, to initiate or to hold a pen and write, these signals, they need to come from the brain, isn't it? From the motor cortex. So the motor cortex will actually release the glutamate, which is excitatory. So what I've done is the pluses. The pluses is excitatory. English, can we speak it? Okay, so from the motor cortex, excitatory signals. Excitatory. Anyway, so they go to the striatum. The striatum is the caudate and the putamen. Please just Google basal ganglia and then look at this nucleus or the nuclei as I'm talking about them, because it helps if you're visual like me. So from the striatum, you get the, let's use green for inhibition. We get the inhibitory signals, which is pretty much GABA. So this inhibition will go to the globus pallidus internus. Again, these are all the neurons in the basal ganglia. And then, of course, please appreciate how quick this happens. These are next to each other, so this is going to be even super fast. So from the globus pallidus, inhibition to the thalamus. This is the signal. From the striatum, also inhibition to the substantia nigra pars reticularis. So what we mean by inhibition of an inhibition, if you're going to put a brake on something that was putting a brake, that means you are stopping that inhibition, right? So by stopping the inhibition means increased activity of the thalamus. That means we are promoting movement, guys. Yay! Now let's talk about the indirect pathway. The indirect pathway, the purpose of this pathway is to terminate movement. Again, the signals are going to be coming from the motor cortex, excitatory to the striatum. Remember, the striatum is the caudate and the putamen, right? So goes to the striatum, and then inhibition from the striatum. Remember the GABA from the striatum, but this time it's not going to the globus pallidus internus like what it was doing in the direct pathway. This time it's going to the globus pallidus externus. Then this globus pallidus externus, it's also going to do inhibitory. From there, it will go to the subthalamic nucleus. So it doesn't go straight to the thalamus like what was happening in the direct pathway. So this time it goes to the subthalamic nucleus. From the subthalamic nucleus, we get excitatory glutamate. And then it will now go to the globus pallidus internus. But the globus pallidus internus, remember, it gives GABA. So it will give us GABA. GABA is inhibitory. So we are going to be inhibiting the thalamus, therefore less movement, right? So we often talk about balancing and homeostasis. So that means if we're going to have smooth movement, not jerky type movement, we need to be able to balance these pathways. We need to be able to balance the direct and the indirect. Okay? So in PD, however, there's gradual degeneration of neurons within the substantia nigra pars compacta. Degeneration of neurons within the substantia nigra pars compacta. So what usually happens is the substantia nigra pars compacta releases dopamine into the striatum, right? Into the striatum. The striatum, we said it was made up of the caudate and the putamen. So the substantia nigra compacta releases dopamine into the striatum. In the striatum, we've got two types of receptors. We have the D1 and we have the D2 receptors. The D1 receptors are excitatory. They're excited by dopamine. So when you are excited, more movement. Still in the striatum, we have D2 receptors. These are inhibited by dopamine. They inhibit the indirect pathway. So if they inhibit, that means less movement. So we need to balance these out. The D1 activity and D2 activity needs to be balanced. So if these are balanced, then we have smooth movement. We will be able to execute our movement or our motor movement smoothly. But now, if these neurons are lost in the substantia nigra pars compacta, the opposite will happen. Instead of getting these excitatory movements and then inhibiting the movement, we're going to have less and less of this. So I've just demonstrated this by just one arrow. Less stimulation of the direct pathway and less inhibition of the indirect pathway. So if it's less and less, that means overall reduction in movement. Overall reduction in movement. And you know, with PD, that's kind of what really happens. We affect movement with this disease. So why do we degenerate? Why the degeneration of these neurons? So we are thinking, or they are thinking, the scientists, we just have to believe, right, that there is accumulation of the alpha-synuclein. This alpha-synuclein, the accumulation, it's also found in Lewy body dementia, hence the association between PD and Lewy body dementia. These people often in the later stages, they get this dementia. So it's a protein, this alpha-synuclein is a protein involved in regulation of the synaptic vesicles and release of neurotransmitters. Signs and symptoms of PD, largely movement. Bradykinesia is the big one. Rigidity, we can have cogwheel or lead pipe. Cogwheel is where you're trying, say, to flex your elbow, but it's like a gearbox, right? Stop, start, stop, start. And then lead pipe is where you have resistance throughout the range of motion. Constant resistance. And then there's hypomimia or hypomimia, which is that mask-like face. We often say mask-like face, which is the expressionless face of PD. Mask-like face. Tremor, pin rolling, it's usually between the index and the thumb where you see that. And there's also resting tremor. Gait disturbance, shuffling gait, where they kind of, they festinate, they shuffle. It's not your normal gait cycle where you have the heel strike, mid loading, and then the toe off. So you lose all that. So it's kind of just shuffling almost on the front part of your toes, right? And so there's no toe off and there's no heel strike. That's shuffling, hence the increased risk of falls in these people. So all of these, number 1 to 5, these are Parkinsonian signs or Parkinsonism. This can also be found in other disorders. So it can be drug-induced or in multisystem atrophy or in progressive supranuclear palsy or normal pressure hydrocephalus. So just know that if you see Parkinsonism, it just means that they're exhibiting this movement type disorders. And then we can also get autonomic disturbance, hypersalivation, constipation, incontinence, and also there's some cognitive impairment there. I guess this is the part where we can also see the Lewy body dementias. So what causes PD? Why are we losing these neurons? Not clear. If we don't know, we say idiopathic, but there is some genetic link. First degree relatives, they have ×2 risk. Familial component can be autosomal dominant or autosomal recessive. There is environmental factors, rural dwelling, exposure to farming or industrial chemicals. Infections also like encephalitis. Age is the largest risk factor. The mean age is 60, mean age. That doesn't mean that younger people can't be affected. There's also percentages where people in their 30s or 40s can be affected. And this one, ladies and gentlemen, us, the fairer sex, we are favored. So there's more male predominance in this one. Diagnosis, how do you diagnose PD? There's no specific labs. It's mainly clinical. But there's a criteria that's been produced. It's called the Movement Disorder Society for Parkinson's Disease criteria. It's an extensive criteria. In that criteria, you've got your bradykinesia there and all the other ones that are supported by that. And of course, there's like some red flags to look out for to exclude PD. You can also do these scans to kind of look into the brain to see that degeneration in the substantia nigra, if these facilities are available to you or for you. Treatment, there is no cure, but there's medications to improve quality of life. You are only improving the quality of life, but you are not necessarily slowing down the progression of this monster. So the goal really is to increase dopamine in CNS, right? Because that's the part that we are losing from this substantia nigra compacta. We are losing the neurons that produce dopamine. So really, if we can find a way to get dopamine into the brain, we can be able to then get the direct pathway and the indirect pathway to work, right? So levodopa is a precursor to dopamine. Why did I say can cross? It can't cross the BBB. No, what am I trying to say? I'm sorry. Ignore what I'm saying. I've just deleted it here, right? So dopamine is the one that can't cross the blood-brain barrier. But then levodopa, it can cross the blood-brain barrier. But guess what? Levodopa is broken down peripherally, even before it gets to the brain, by this enzyme called dopa decarboxylase. So we need to find a way to stop this enzyme from acting. So we can use an inhibitor like carbidopa. It's given so that we can get more levodopa get into the brain. So we have levodopa. We want it to become dopamine in the brain. Once this is now in the brain, so carbidopa is here to stop the breakdown of levodopa so that we can get more levodopa into the brain. So we have levodopa, carbidopa. So we have other dopamine agonists like pramipexole or ropinirole, selegiline, amantadine, tolcapone and capone and tacapone. But these don't necessarily get used because of this reason. So I guess if we just know these ones here will be good, right? The problem though with using these medications, there is a phenomenon called the on-off phenomenon in PD treatment with the use of levodopa. So over time, the window, so it's like this, the on-off, and then over time, this becomes like this, right? So that the window for controlled symptoms gets smaller, while the off state of rigidity and uncontrolled symptoms will become more and more. So again, this on-off change can happen so quickly, like the change of a light switch, like, right? So with this on-off scenario, we also have what we call the peak dose dyskinesia. The dyskinesia is that difficulty in movement that happens with the on-off phenomena, but also with the peak dose, again, peak dose of levodopa, we can also get this dyskinesia. So when we get to that point in time where now levodopa is not really benefiting us, we can use deep brain stimulation. It's an option for these patients who no longer get any benefit from levodopa, from the medication. So the deep brain stimulation is where you put the this stimulator under the skin, under the clavicle, and then the electrodes will be in the ganglia. Yeah. Thank you guys. Hope you enjoyed this video. With love.